Hello everyone and welcome to another video of We Teach. My name is Vashni Selvan and today's video on interpreting chest x-rays is divided into two parts and it is a collaboration video with the MBRU Radiology Club. This is how a normal chest x-ray looks like with the parts labeled in the image. Do pause the video and take a few minutes to get accustomed to this image as it will help you identify what's abnormal in the upcoming slides. We will be using the 7-step approach to interpret a chest x-ray. Firstly, we'd like to check the patient's ID. We need to make sure that we are interpreting the correct chest x-ray. So we'll have to check the chest x-ray if it is the right one. Your patient's details will be mentioned on the x-ray. While you're presenting to your attending or to your professor, you will need to make sure to say the name of the patient, their age or date of birth, and when the chest x-ray was taken. After checking the patient's details, we will have to inspect the image quality of the X-ray. And we can do that by checking the projection, penetration, inspiration, and rotation of the X-ray. Projection is of two types, anteroposterior and posterior-anterior. In anteroposterior, you can see that the patient is seated and is facing forward with his back resting on the plate. Posterior-anterior is when the patient is standing and is turned behind with his chest on the plate. This is how a posterior-anterior chest x-ray looks like compared to an anteroposterior chest x-ray. In the posterior-anterior chest x-ray, you can see that the posterior ribs are more prominent, whereas in the anteroposterior chest x-ray, you can see that the anterior ribs are more prominent. Now, we'll have to check if the penetration is adequate or inadequate. We can check that by checking the visibility of the vertebral bodies. In an adequately penetrated x-ray, you can barely see the intervertebral discs. In an over-penetrated X-ray, you can see the intervertebral discs very clearly. And in an under-penetrated X-ray, you are not able to visualize the intervertebral discs. We will have to check if the inspiration is adequate or inadequate. And how can we do that? By being able to count either 6 anterior ribs on the X-ray, as I'm showing you, or by counting 10 posterior ribs on the X-ray. By comparing these two X-rays, we can see that this is a good inspiratory effort as I can clearly count 6 anterior ribs in this X-ray, whereas this one shows poor inspiratory effort because I am not able to count 6 anterior ribs or 10 posterior ribs. To check if the X-ray is rotated, we will have to see the distance between the heads of the clavicles. This patient is rotated to the left side. We will then move on to the airway aspect of the 7-step approach. We will have to see if the trachea is central or displaced. And we will also have to keep in mind that sometimes the trachea is falsely displaced when it's rotated, or if there's true displacement due to pathology. For example, in this image here, the trachea is midline. However, the patient is slightly rotated towards the right. And in this chest x-ray, we can see that there is a leftward tracheal deviation due to right-sided pleural effusion. We will then move on to the breathing aspect. The lung fields should generally be uniformly dark gray as shown in this image. If there's increased lung field density, it could be because of airspace disease such as pulmonary edema in this chest x-ray and other airspace diseases such as pneumonia, masses, pleural effusions, or atelectasis. Decreased lung field densities can happen in pneumothorax and in COPD. We will then inspect if there's any pleural effusion, and how we can gauge whether a chest x-ray is showing pleural effusion is by checking if there's any blunting of a costophrenic angle. As I'm showing here, the right costophrenic angle in this x-ray is blunted, and we can clearly appreciate the costophrenic angle on the left side of the X-ray. We will then see how the hilar are shown on the X-ray. The left hilar point should ideally be higher than the right hilar point as indicated in the image. Both hilar should be in the same density and they should not have any lumps or convex margins. In these two images, we can see that due to upper lobe collapses, be on the right side or on the left side, the respective side's hilar is pulled up. For example, over here the right hilum is pulled up and over here the left hilar is pulled up. This indicates volume loss, and that's why the hilar is being pulled up. We will have to check if the hilar is hypervascular as shown in this image. You can see that there is bilateral hilar enlargement. Hyperinflation is when the hemidiaphragmatic contours are flattened. And this is an X-ray of a COPD patient. And how do you know it's hyperinflated? When you're able to count more than 6 anterior or more than 10 posterior ribs above the diaphragm level in the mid-clavicular line. And that concludes part 1 of the Interpreting Chest X-ray series. Thank you for listening and stay tuned for part 2.